Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Abigail, would you like to introduce yourself?
Hello, everyone. My name is Abigail Burton. I am interning this summer at the Blum Patient Family Learning Center here at Mass General.
Thank you. Today's program is part of our genetics series, a special collaboration between the Blum Center and the Center for Genomic Medicine at Mass General. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has mute so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Abigail, who will introduce you all today's guest speaker.
All right, thank you, Amy. We would like to give a warm welcome to Diane Lucente to speak today on her presentation titled, I Have a Family Member with Dementia, Am I at Risk? Diane Lucente has a master's degree and is a licensed certified genetic counselor. She worked as a research technician investigating genetic causes of neurological diseases for several years before training to become a genetic counselor, a role that she has filled for 25 plus years. For around the past 20 years, she has been a research and clinical genetic counselor in the MGH Center for Genomic Medicine and the Department of Neurology. She provides clinical care to patients and families with neurodegenerative and neurodevelopmental conditions, including diagnostic testing for patients with symptoms and asymptomatic testing for individuals with a 50% chance of inheriting a genetic condition. She is also actively involved in research, the focus of which is to try and determine the natural history and underlying causes for many neurodevelopmental and neurodegenerative conditions. So everyone, please join me in welcoming Diane today.
Good afternoon. Thank you for inviting me. I'm happy to be here and have this opportunity to discuss this topic with everyone. I have a presentation with some slides and then certainly left for some time for some questions at the end. If anybody has any questions or wants to discuss anything. And then just prior to beginning, I want to state that I have no conflicts of interest or nothing to disclose. So let me just share my screen. Okay, can everybody see my presentation? Yes, we're okay. As was mentioned, I am a neurogeneticist here at Mass General, involved in both clinical care and research for our neurodevelopmental as well as neurogenetic conditions. We frequently get phone calls and questions from patients, families, outside folks regarding family histories of dementia, Alzheimer's. So I thought this would be a nice opportunity to discuss this information in a more public way and try to answer any questions. I think one of the best ways to start off is to discuss what dementia means. Dementia is not a specific disease or a condition. It's actually a symptom. So there's lots of different reasons why someone could have dementia. But dementia is a general term for impaired ability to remember, think, or make decisions that interferes with everyday activities. Certainly, Alzheimer's is the most common type of dementia, but they're not musically exclusive. Not everybody who has dementia has Alzheimer's, okay? And though dementia mostly affects older adults, it is not a part of normal aging. The thing to remember is that dementia is a common occurrence, and it impacts, 50 million plus or minus folks have dementia. And in the last several decades, there's been lots of research, lots of publicity. It's been in the media a lot, discussing genetic contributions for dementia and neurodegenerative conditions. And the goal of this is hopefully to try to understand these neurodegenerative conditions, and really with a better understanding of the conditions, our goals are to hopefully implement better diagnosis, treatments, and potentially a cure someday. So normal age-relating memory changes would include such things as occasionally misplacing our keys, struggling to find a word, but you remember it later, maybe forgetting the name of an acquaintance, or maybe a most recent events. But our knowledge stays intact of experiences that we have over our life, and languages and memories stay intact. So we all age. That's part of being a human being. Certainly, my memory is not as good as it used to be when I was younger, but I don't have dementia. When we're talking about common types of dementia, or what we're concerned about, or what do we think this has an impact for the patient or other family members, really diagnosis is important. I work closely with my neurology colleagues, really trying to determine what's the underlying cause of the dementia, and does genetics play a role, or is there something I can help contribute, not only for the patient, but for family members. So certainly Alzheimer's disease is the most common cause of dementia, causing upwards of 60 to 80% of dementia. And there's some different percentages in different ethnic groups. Vascular dementias are very common. As the name implies, it's something to do with blood supply, whether it's the carotids, whether someone's had a stroke. So there's some disruption of blood supply and therefore oxygen to the brain. And this unfortunately can cause some damage and then can interfere with our cognitive abilities. Lewy body dementia is a type of neurodegenerative condition. It interferes with or can cause symptoms related to thinking, memory, behavior, mood. It's typically not one of the genetic forms of dementia. It has a late age of onset, and we typically only see one person in a family with Lewy body dementia. So it's not considered a hereditary condition in most forms. There's likely genetic components that maybe help contribute to it, but not something that has the potential typically. There's always rare exceptions in the world of genetics of something that would be passed from a parent to child. I'll talk about frontal temporal dementia in a moment. It is the most common cause of early onset dementia. Few people are aware of FTD historically. Until recently, Bruce Willis was diagnosed with this condition. Unfortunately, I think it has brought it more into public awareness. But again, it is the most common cause of early dementia, and it actually has a quite large genetic component to it. Mixed dementia is, as its name implies, there's multiple causes for someone's symptoms of dementia, these cognitive impairment, and the most common combination would be someone who has Alzheimer's as well as vascular dementia. And then the reversible dementias. And again, when this comes back into finding the underlying cause of someone's dementia, can certainly be crucial, because there are types of dementias that are reversible. If someone has a brain injury or a tumor, if there's an infection, if there's some type of toxin, is there some metabolic disorder, whether it's a vitamin deficiency, is there maybe a thyroid issue, and issues with the thyroid hormones are contributing to someone's cognitive decline. So again, finding or trying to determine, at least if not possible, determine the exact cause of the dementia, to cross out potential things that are on the list, a tumor, a virus, a toxin, so that we can try and help determine what is causing dementia for a person. Most cases of dementia are not straight genetic conditions. There's a genetic alteration, and therefore it's causing someone to have these symptoms. Most cases of dementia, as well as most cases of lots of diseases that we're familiar with, are what we call multifactorial or complex. There's typically multiple factors that contribute over time that cause us to develop these symptoms. So whether we're talking about dementia or we're talking about late onset diabetes or heart disease, for these conditions, there's likely multiple genetic factors that we're still trying to learn that perhaps increase someone's susceptibility or predisposition to developing these conditions. But the genetic factors by themselves are not sufficient to develop symptoms. There's some outside factors that likely contribute. Should be diet, it could be lifestyle, it could be an exposure. So again, most forms of dementia are these complex multifactorial type and not straight hereditary type, where we see a genetic alteration being passed from one family member to another. Okay. So given that overview of dementia, now I'd like to talk about some of the rarer hereditary types, and then talk about more about what people can do who likely have the most common non-hereditary type of dementia, either for themselves or for family members. So as I mentioned, frontal temporal dementia is the most common cause of early onset dementia. It actually has a quite large hereditary or genetic component to it. This is seen in folks typically in their 50s plus or minus. So certainly several decades before we would anticipate seeing signs of Alzheimer's disease. FTD is a group of conditions. It's also referred to as frontal temporal lobar degeneration. So there's multiple different types of conditions that can arise under this umbrella. They all involve degeneration of the frontal and temporal lobes of the brains, and it causes this progressive change in behavior, personality, language, and movement. The most common type of frontal temporal dementia is behavioral variant, FTD, which accounts for 50% of cases. It's also known as Pick's disease. And for these folks, there's quite significant changes in behavior and personality as the frontal and temporal lobes are affected. Folks lose interest in things that they used to be interested in. They have this loss of empathy or concern or compassion for folks around them. They can be inappropriate at times, which can be complicated for family members and loved ones. They can have maybe some obsessive or compulsive behaviors. They frequently have a newfound love of sweets and can gain some weight. They can be involved in scams or being taken advantage of. They can frequently receive patients who have been misdiagnosed with a psychiatric condition because of these behavioral changes, maybe have been arrested because of some of their abnormal behaviors. And so it's a quite complicated condition, not only for the patient, but for the families. And it has a very large genetic component to it, which I'll discuss in a minute. Another less frequent type of FTD is called primary progressive aphasia. The speech changes that we can see in the behavioral variant of frontal temporal dementia have to do with understanding, comprehension, word retrieval, difficulties understanding and reading. So a less common type of frontal temporal dementia typically starts off with virtually just speech issues in one of these three different forms. And these patients can progress to having the behavior and personality changes that we can see in the behavioral variant, but typically the majority of symptoms are around speech. And this is less likely to have a genetic cause, certainly contributing to it, but not cause in the straight hereditary form of these types of conditions. Less frequent types of frontal temporal dementia or degeneration conditions are cortical basal syndrome, progressive supranuclear palsy. These also have symptoms involving movement, language, behavior. They can frequently have eye abnormalities, eye movement changes involved with them, and they are less likely to occur. They're very rare, and they're less likely to have a straight genetic cause to them. From age of onset until death, it's typically about 8 to 12 years. For most of these patients, certainly that can be variable. As mentioned, it occurs at a much younger age, decades younger, than what we typically associate with dementia. Therefore, it's often misdiagnosed. Neurodegenerative condition is not something that's typically looked at first, at least in folks in their 40s and 50s. And because it has this behavior, personality changes, and occurs at a young age, it has a much bigger impact on families, finances, and work. So it can be quite complicated and devastating, not only for the patient, but for the folks that love the patient. Again, it is more common than folks think. Again, it was not well known at all, not only by the public, by certainly medical professionals too. Again, with the recent diagnosis of Bruce Willis and mentioned in the public media, that certainly I think more people have become familiar with frontal temporal dementia. It is the third most common type of neurodegenerative process, third only to Alzheimer's and Lewy body, and it accounts for roughly 5 to 15% of all dementias. There is currently an estimated 50 to 150,000 Americans with FTD right now. Again, it has this very early age of onset, and it is the most common cause of early onset dementia. We have an FTD unit here at Mass General, and I've had patients in their 20s with FTD, but there's certainly been older presentations. Again, these are just ranges that we give. And up to 1/3 of FTD cases can have a positive family history, which we'll see is quite significant and much higher than we see in Alzheimer's disease. Here's just a pie chart to help break up what we see in frontal temporal dementia families. As you can see, there's folks that have a strong family history, and the vast majority of them will have a genetic finding. We have a proportion of folks that have a family history of maybe another neurodegenerative condition as opposed to frontal temporal dementia. We can see ALS, amyotrophic lateral sclerosis, occurring frequently in families that have FTD, as well as some other neurodegenerative conditions. And almost half of these folks are going to have a genetic finding. And certainly the largest proportion of FTD patients will have no known family history or no obvious family history. Sometimes our family history is missing information. We all have family dynamics. Maybe there's been some last contact. Maybe someone's been adopted. Maybe a family member died early, unfortunately, due to a car accident, say in their 30s. So we wouldn't know what their FTD status was. But even in these families that appear to have sporadic or no family history of FTD, we do find a genetic alteration in a proportion of these individuals also. So when we're thinking about FTD, upwards of 30 to 40% of them can be familial. There's multiple genes that have been identified that can cause frontal temporal dementia when there's a change in the gene that causes it not to work correctly. We still have more genes to find because just the genes that we know about currently don't account for all of our patients that obviously have hereditary FTD, where there's multiple family members and multiple generations. So genetic testing is not exhaustive, that we can perform genetic testing and not find an alteration in a specific gene but hereditary FTD still could be occurring in that family. I've just listed the 3 most common genes here that are associated with hereditary FTD. And again, you can see the big impact that genetics has in this specific condition. And I put these numbers here to show them in comparison with Alzheimer's, because certainly folks are much more familiar with Alzheimer's disease, more likely to have a family history of Alzheimer's disease. That, you know, for the progranulin gene, that it accounts for maybe 5 to 10% of all FTD cases, but when there's a family history, 20 to 25% of those folks will have an alteration of this gene. Again, another gene, microtubule associated protein tau, we call that MAPT for short. Again, will account for a proportion of all FTD cases, regardless if there's a family history or not. But when there is a family history, about a quarter of those folks will have an alteration of this gene. And then this gene, chromosome 9 open reading frame 72, or C9orf, which was just discovered in 2011. And we just started performing testing for patients and families in 2012, is by far the biggest cause of not only frontal temporal dementia, as well familial as well as sporadic, but also ALS. So this was a big finding and provided a lot of information for families who have hereditary forms of these conditions. Given the large impact of genetics on frontal temporal dementia, our current guidelines recommend that all patients, so a patient has symptoms, should be offered genetic testing for frontal temporal dementia. So that's what I wanted to say about FTD. Again, it is the most common cause of early onset dementia. It has a large genetic contribution to it, and certainly patients who have symptoms of FTD, recommendations is that genetic testing should be offered to them. Okay. So now I'd like to switch to Alzheimer's disease, which is certainly a condition that more people are familiar with, more people are impacted with, more people are likely to have a family member that has this condition. In Alzheimer's disease, a degenerative brain condition. So unfortunately, the neurons in our brain are dying, and it's progressive condition. It's caused by complex changes in cell damage. It leads to dementia symptoms that generally get worse over time because it is a progressive condition. The most common early symptom, or typically the presenting symptom for Alzheimer's disease, is trouble remembering new information because the disease typically impacts the part of the brain associated with learning. Okay. Most cases of Alzheimer's do not have a single genetic cause. So there's a single genetic alteration in a gene, and that is sufficient to cause symptoms of the disease. Instead, most cases of Alzheimer's are that multifactorial complex type that I mentioned, that it would be influenced by multiple genes in combination with lifestyle and environmental factors. So certainly a person may have one or more gene that causes increased susceptibility or predisposition. And on the flip side, I like to point out, it could also reduce someone's risk. There are likely genetic factors. There are some known genetic factors out there that potentially reduce someone's risk. Okay, so genetic factors are not always bad. They can sometimes be protective. So therefore, there's likely multiple genetic factors that may contribute to the development of Alzheimer's disease, but they by themselves are not sufficient to cause. There is a rare hereditary form of Alzheimer's disease that can be caused by pathogenic, that means disease-causing, alterations of a gene. The most common genes that can be associated with hereditary forms of Alzheimer's disease are called APP, presenilin 1, presenilin 2, and other unknown genes that we have yet to discover. And I'll talk more about these genes in a moment. As I mentioned, hereditary Alzheimer's disease is very rare. It only accounts for approximately 1 to 2% of all Alzheimer's patients. So again, to see the difference between frontal temporal dementia, where maybe 30 to 40% of FTD cases are familial with likely genetic causes, only 1 to 2% of Alzheimer's patients will have genetic alterations that cause their Alzheimer's. Typically in families with hereditary Alzheimer's disease, typically, not always, we would see earlier ages of onset, and so less than 65. Typically, these families have onset in their 40s or 50s, and there's usually multiple affected family members. Okay. So let's talk about Alzheimer's and genetics a little more. I'd like to first talk about the ApoE gene that is in the media frequently. It's been in the media even more frequently recently due to an article that was published and discussion about it in the New York Times. Chris Hemsworth, the actor, has discussed having ApoE testing. So it is something that's out there in the general population. Patients and family are aware of this. They are interested in this. You can get ApoE testing on some of the direct-to-consumer genetic companies or websites that are available to the general population. So I'd like to spend some time talking about this before I talk about some of the more rarer hereditary forms and how we do testing for patients. I think the important thing to think about when we're talking about genetic testing, doing the testing is not the only important factor. What is important about genetic testing is ordering the correct test, but also having someone, a professional, whether it's a genetic counselor, someone else trained in genetics, another medical professional, to be able to discuss the results and help interpret them with the patient. Okay, so because you can order genetic testing for yourself on some of these direct-to-consumer sites, doesn't mean that they're always the best way to go. Okay, so with that said, let's discuss the ApoE gene a little bit. Investigators' research has long supported the concept of late onset Alzheimer's. So not this rare hereditary Alzheimer's that affects only 1 to 2% of patients, is a complex disorder, as we discussed, that may involve multiple susceptibility genes. And this has been well known for a long time. There's multiple genes that we know may increase or modify someone's risk for Alzheimer's. Certainly the apolipoprotein E, we call that ApoE for short, gene is the strongest genetic risk factor for Alzheimer's. The ApoE gene helps carry fats such as cholesterol in our bloodstream. We all have the same genes. That's what makes us humans. Humans have the same set of genes. So everybody, all humans, have the ApoE gene. We all have it. We all want it. We all need it. We have 2 copies of each gene, one that we get from mom and one that we get from dad. So every human has 2 copies of the ApoE gene. Now there's genetic variation within our genetic information. That's why all humans don't look or act the same. And there's certainly multiple different forms of the ApoE gene, with the most common type being what we call E2, E3, and E4. So as each of us has 2 copies of the ApoE gene, there's multiple combinations that we can have of the different forms. So individuals could be E2, E2, E3, E3, E2, E3, E3, E4, and E4, E4. In the context of Alzheimer's disease, the ApoE2 form of the gene is thought to have some protective effect. So therefore potentially reducing the risk of Alzheimer's, not eliminating it, just potentially reducing the risk. The E3 form of the ApoE gene is thought to be neutral, so it's not associated with a potential increased or decreased risk for Alzheimer's. And the E4 form of the gene is thought to be associated with an increased risk for Alzheimer's disease, but an increased risk, not that it causes Alzheimer's disease. So I think that's an important distinction. Just as elevated cholesterol is associated with an increased risk for a heart attack, but it doesn't mean it's going to cause you to have a heart attack, or that you'll definitely have a heart attack if you have elevated cholesterol. So let's talk about the E4 form of the gene. As I mentioned, the ApoE4 allele, that's just another way of saying form of the gene, is associated with an increased risk for mild cognitive impairment or dementia due to Alzheimer's. So in the general population, every human has an approximate 10 to 12% risk for Alzheimer's disease over the course of their lifetime, if they live long enough. Okay, because there are certainly things that can cause our lifespans to be shortened. AD is often described, as we discussed, as multifactorial, which could include a complicated interaction of both environmental, lifestyle factors, and genetic factors. Some genetic risk factors, such as ApoE, are alone not sufficient to cause medical conditions. Therefore, sometimes a person can have the risk allele, so the E4 form of ApoE, and never develop symptoms of Alzheimer's. So I think that's an important fact to point out. Again, if you have the E4, that doesn't mean you're going to develop Alzheimer's. And if you don't have an E4 form of the ApoE gene, that doesn't rule out the possibility of Alzheimer's either. So if someone has one E4 allele, one copy of their ApoE gene that has the E4 form, they will have about a 20 to 25% chance to develop Alzheimer's by the age of 85. So if you recall, we just discussed that the general population risk for Alzheimer's disease is 10 to 12%. So perhaps having one copy of the E4 form of ApoE would double someone's risk to develop Alzheimer's. If someone has two copies, so both ApoE genes are E4, they have approximately a 30 to 55% chance to develop Alzheimer's by the age of 85. So you could also say they have a 50% chance or more that they will not develop Alzheimer's by the age of 85. Certainly other factors such as biological sex or ancestry may alter these risk estimates. Certainly most of the genetic alteration into this risk factor has been done on some skewed populations, mostly Northern European Caucasians. So these are generalized risk estimates. There are some more specific ones that we're trying to generate. There's some data that suggests that there may be some different risks associated with different ethnic groups. So just remember, ApoE is not necessary to cause Alzheimer's, which again suggests that other factors may be involved. And, you know, almost half of the folks who have Alzheimer's do not have the E4 version of the ApoE gene. So again, if you are not found to have the E4 allele, it doesn't mean that you're not going to have Alzheimer's either. Okay. So it's rare that we do testing for ApoE on folks with symptoms, and even rarer that we do testing for ApoE on patients without symptoms. So just to summarize ApoE and the potential risks associated with it, these are words and numbers, but I know sometimes graphs or visuals work for folks. So I wanted to just include this also. So remember, here's our general population risk for Alzheimer's. folks who have a 2 allele, it's thought to potentially reduce your chance that for having Alzheimer's, but again, not eliminating it. E3 maybe a little neutral for most populations, and then E4 increasing the risk, but certainly not something that is definitely going to cause everyone to have Alzheimer's disease. Again, there's been lots of media coverage in regards to this, and certainly recently an article came out in Nature Medicine talking about folks who are homozygous or have 2 copies of the ApoE4 form of the gene. They're stating that this represents a distinct genetic form of Alzheimer's disease. So in this paper, the data was taken from 5 very large cohorts or groups of Alzheimer's patients from big studies that include pathology, looking at people's brains, biomarkers, other markers that we can use to help assess if someone has Alzheimer's or not, if they're at an increased risk. So whether it's proteins and some body fluids, the blood, the spinal fluid, or maybe doing imaging. So it's looking at a large group of cohorts with Alzheimer's disease that had some pretty substantial information available with them. Almost all of the ApoE4 homozygotes, so folks who had 2 copies of the E4 allele, had Alzheimer's pathology, so findings in the brain of these plaques or tangles that are associated with Alzheimer's disease. And most of them had positive Alzheimer's biomarkers. I think the thing that's important to point out, just because someone has Alzheimer's biomarkers or Alzheimer's pathology in the brain, it does not mean that they have Alzheimer's symptoms. So we have patients that don't have symptoms. We look at their brains after death, and there's findings suggested for Alzheimer's, but they don't have any symptoms. So I think that it wasn't discussed accurately or presented as accurately as it could have in the media, that when they're talking about this form of Alzheimer's disease, it's based on pathological or biological findings of Alzheimer's disease, but not on the actual symptoms or the clinical presentations seen of Alzheimer's disease. The age of onset was earlier for folks who were E4 homozygotes. So those folks who did have symptoms, it was earlier if they had 2 copies of the E4 allele, but we already knew that, right? But based on this information, the pathology, the biology, they concluded that these APO4 E homozygotes were this distinct form of Alzheimer's disease. Again, there were some issues with this paper, as there are with all papers. No papers are perfect, and when we're reading papers or scientific information, medical information that's presented, we have to keep in mind that no paper is perfect, and there's limitations associated with information. Again, they defined Alzheimer's based on pathology, so what was seen underneath the microscope, rather than clinical symptoms, or what was seen in the biomarkers or in the body fluids or in the imaging, other than symptoms that a person was presenting or had been presenting. So this is very useful for research purposes, absolutely, but it may be misleading for in the clinical setting when we're thinking about patients and families. It's also worth emphasizing that the paper stated that E4 homozygotes had full penetrance, or everybody with this would have this finding. They were talking about, again, the pathology and not the dementia. So we knew these findings, so that didn't change our understanding of what we knew about the pathology of E4 and Alzheimer's disease. There may have been some bias with the sample set that they used that could be a potential issue for the findings that they had. Again, it was from these national coordinating centers for Alzheimer's disease. Great set of folks to do research with. But again, the cohorts were probably select population and weren't representative of every ethnic group, of every population. So maybe the information is not correlated for every individual. Certainly, they found that E4 homozygotes had dementia approximately 88% of the time, and which that is not the information for the general population, as we just discussed, which is 50, 55% or 60. There may have been some concerns with how that data was analyzed, if it wasn't corrected for this ascertainment bias. Again, it was a subset of the population. The folks or the samples that were included were not representative of everyone in the population. So if this fact isn't corrected for, it can skew the data. So again, their conclusions may not be for the whole AD population, but maybe more relevant to the specific subset that was used for this paper. There was a comment about this paper or an article regarding this paper in the New York Times that lots of people have seen. I think it was important, not only the things that I've already mentioned, but mentioned in this paper is regardless of this new information that's been reported in this paper, it's still not appropriate to test folks for ApoE who don't have symptoms, okay? And these are guidelines sent forward by multiple regulatory boards, such as the American College of Medical Genetics, the National Society of Genetic Counselors. Even with this new information based on the pathology of Alzheimer's, still the recommendation is not to offer testing for folks who don't have symptoms for ApoE genotype. So in conclusion, while the association of the ApoE4 allele with Alzheimer's disease is significant, ApoE genotyping, knowing if someone has 2, 3s, or 4s, is neither fully specific nor sensitive. Again, folks can have Alzheimer's without having the E4 of the version of the ApoE gene, or folks that do have Alzheimer's cannot have ApoE. While ApoE genotyping may have an adjunct role in the diagnosis, if someone has a confusing, unclear presentation of Alzheimer's, maybe it would be helpful to know their ApoE status. So we might use it in rare instances to help in the diagnosis of someone who's symptomatic. It still appears to have little role at this time in predictive testing for folks without symptoms. Okay. So that we get lots of questions about ApoE, about folks wanting testing to help assess their risk for Alzheimer's if they're asymptomatic. But the current guidelines still recommend that we don't do this testing for folks without symptoms, and we rarely do it for folks with symptoms. So what can we do for patients and family members? So what can we offer families, patients who are concerned about their loved one, about their own risk? Well, as we already discussed, for patients who have frontal temporal dementia, the current recommendation is that any patient with frontal temporal dementia, regardless of their age of onset, regardless of their family history, they should be offered genetic testing because we're concerned that there may be some underlying genetic cause. So let's talk about Alzheimer's disease. When we see a patient who has Alzheimer's disease, who should have testing? Everyone? Like we do or offer for frontal temporal dementia patients. We offer genetic testing to all ALS patients too. Probably not for everyone. As we discussed, hereditary forms of Alzheimer's are only account for about 1 to 2% of patients. So typically we look at someone's medical and family history to determine if we should offer them genetic testing for Alzheimer's. Are there multiple family members? Is there earlier ages of onset for our patient or family members. Why would we offer someone who has Alzheimer's genetic testing? Well, it could confirm their clinical diagnosis. If they have an alteration of one of the genes associated with hereditary hereditary Alzheimer's disease, that would confirm their clinical diagnosis. Lots of clinical trials now are based on the underlying genetic cause for symptoms. So if we were to identify a genetic alteration in an Alzheimer's patient, they may qualify for a clinical trial that could help slow or reduce the progression of the disease. And if we know a hereditary form of Alzheimer's is occurring in a family, we can do risk assessment for other family members, siblings, offspring, and potentially offer them genetic testing. Once we determine if this is something inherited or something maybe that someone has due to a new genetic alteration. When we do testing, there's different ways to test folks. We have panels that are for genes that are associated with dementia. Maybe we could start off with just a single gene first. Whole genome sequencing and whole exome sequencing are looking at all the genetic information of an individual. All their genetic information is whole genome sequencing. Whole exome sequencing would just be the genes and not some of the other DNA that we have. Genetic testing, while it can be helpful, sometimes the results are not always straightforward. If we have a positive result, that means we found a genetic alteration that is pathogenic or disease-causing. If we find a negative genetic result, that means there was not any genetic alteration that has the potential to cause medical concerns. There may be some of these normal variations that we see in humans, but they're benign. Sometimes, unfortunately, we have a genetic finding that is we don't have enough data to know if it is potentially one of these disease-causing alterations of a gene, or if it's just some of that normal genetic variations that we see in humans. So it's called a variant of uncertain significance and leaves us in this gray zone until we have some more data. It can be quite anxiety producing for patients and their family members when we find a genetic alteration that we are not able to interpret correctly at that time. Hopefully, in the not distant future, we will accumulate additional data that will allow us to better classify a genetic alteration. So if we're doing testing for a patient, one of the things we look at is their family history. So this would be typically what I would expect to see for most, not all, Alzheimer's patients who would have a hereditary form of the condition. Folks who are colored in have Alzheimer's disease. Circles are females, squares are males. Here you can see Alzheimer's is being passed from an affected parent to children over multiple generations. So we see this hereditary form in the family. Most cases of hereditary Alzheimer's disease are dominant. If you recall, we have 2 copies of each gene, one that we get from mom, one that we get from dad. In a dominant condition, only 1 copy of the gene needs to be altered in order for a person to have symptoms. So if we look at this picture here, this man has Alzheimer's disease, and big A would be the altered copy of the gene, whichever gene we're speaking of that's causing Alzheimer's disease for him. But he would also have another copy of the same gene that's not altered and not associated with the potential to cause Alzheimer's disease. So as our parents pass on half of their genetic information to us, this man is going to pass on 1 copy of this gene to each offspring. So for each pregnancy, there would be a 50% chance that this person could pass on the altered copy of the gene, and therefore their child would be at risk of developing Alzheimer's disease also, or the unaltered copy of the gene, and then their child would not have an increased risk to have Alzheimer's disease. They would, however, still have the general population frequency. So when there is a dominant hereditary form of Alzheimer's disease occurring in the family, the risk to a patient's offspring are 50% that they will inherit the genetic alteration and potentially develop Alzheimer's themselves. if this person inherited this genetic alteration from their parents, then there would be risk to their siblings and potentially other family members. So this is just a schematic view of that. So again, here's our parent that has Alzheimer's disease due to a genetic alteration of a gene, but they have another copy of that same gene that's not altered. And then we can see the possible reproductive options, and there would be a 2 out of 4 or 50% risk for each pregnancy that the child would get the altered copy of the gene. So when we're offering testing for Alzheimer's disease, the main genes are known to be associated with hereditary forms of Alzheimer's are called APP, presenilin 1 and presenilin 2. We know that there's genes that we still have to find that can be associated with hereditary forms of Alzheimer's disease, because even when we have families that look similar to those pictures that I just showed you, where there's multiple family members who have Alzheimer's disease, we can test for these genes and still not have any findings. So, 20 to 40% of folks who appear to have a hereditary type of Alzheimer's disease will not have any genetic findings. There is some rare instances where we would offer testing for ApoE. Lecanemab is a medication that has recently been approved for treatment of mild cognitive impairment or early dementia stages associated with Alzheimer's. It helps break down the buildup of this plaque, this amyloid, that can occur in the brain and cause damage to brain cells. Like all medications, there is a potential harmful risk associated with this medication that is associated with this ApoE4 allele again. It's for a medical condition called amyloid-related imaging abnormalities, or ARIA. These are micro brain bleeds that can cause swelling also, and there may not be any symptoms associated with it. In rare instances, side effects can be life-threatening. Everyone has a risk for ARIA if they take lecanemab, but folks who have the E4 version of the ApoE gene have an increased risk, with the greatest risk being for folks who have E4, a smaller risk for folks who just have one E4, and then a smaller risk for folks who have no E4 alleles. So as you can imagine, this is quite complicated. We know Alzheimer's patients have an increased frequency of the E4 version of ApoE, and it's that same ApoE4 version of the gene that can put them at an increased risk. Because of this increased risk associated with ApoE, it is at least recommended, some sites require Alzheimer's patients to have ApoE genetic testing prior to starting lecanemab. If there are patients or family members without symptoms, what can we offer them? Lots of patients have family histories of Alzheimer's or dementia. As you mentioned, typically few have hereditary Alzheimer's. There are many factors that can impact the chance to develop Alzheimer's. Again, we know multiple genetic factors or outside factors can increase someone's risk for Alzheimer's disease. Rarely, Alzheimer's patients have hereditary Alzheimer's. So we do not recommend ApoE genetic testing in individuals without symptoms, and only for a small proportion of folks who do have symptoms. If someone has a concerning family history with multiple affected family members with early ages of onset, or a mutation has been found in a gene associated with hereditary Alzheimer's disease, they should be seen by a genetic counselor. When we do genetic testing for family members without symptoms, there's lots of things to take into consideration. Again, we can have different types of genetic results. Just because someone has the same genetic alteration as their parent, we would not be able to predict the age of onset, the symptoms, or the progression. Penetrance refers to if you have a disease causing alteration of a gene, what's the likelihood that it will cause you symptoms? Rarely do genes have what we call 100% penetrance, where all folks with that genetic alteration will have symptoms. And so maybe someone could have the same genetic alteration as a parent, but never develop symptoms themselves. And certainly for folks without any symptoms, there's lots of psychological factors that we need to take into consideration. If they're positive, they have the same genetic alteration as a parent, but also if they're negative, they don't have this genetic alteration that's been identified in their family, but yet other family members may be ill or at risk. We talk about discrimination. GINA is a federal law that helps protect against genetic discrimination, but it only applies to employers and insurance. And also, is there anything someone could do with this genetic knowledge when they don't have any symptoms? Is it useful for life planning, reproductive planning? Is there a potential intervention or trial that's available to them? So there's lots of different considerations why someone without symptoms would want to pursue genetic testing, and certainly help and discussion and information from professionals is very useful in this instance. So if genetic testing is not the answer when someone has a family member with dementia, what is? There's some different things you can do. There are ways to reduce your risks, such as exercising, eating a healthy diet, getting enough sleep, keeping your mind active, not smoking, maximizing your health. Family members may also consider participating in research. So there's lots of lifestyle factors that you can do. There's also a place you can go to be seen if you want more information about your own neurological health and risk. We have here at Mass General the McCann Center for Brain Health, and its mission is to maximize brain health and prevent age-related brain disease. It's a team of clinicians that monitor and preserve brain health and promote vitality, reduce risk, and help people feel plugged in. So thank you very much for the time. I know I went over, so I apologize for that, and I certainly will take any questions if they're available at this time.
Thank you, Diane. I believe you addressed majority of these questions, but perhaps you may have, additional thoughts you'd like to share. We have an audience member who mentions there is dementia on her mother's side of the family. She had bought a 23andMe kit a few years ago, but has not used it yet. Should she be worried about her insurance company getting access to the results at some point? Could this impact her coverage?
So that's a great question. 23andMe is a company that's out there and available to the public. They do offer ApoE genotyping is something that's available for folks. And, we actually get a lot of referrals at the hospital for folks who have pursued 23andMe, come back with this genetic information, and they haven't had good conversations about what it means and what it doesn't mean. So I think that's something to take into consideration also. Typically if folks are paying out of pocket, it wouldn't be something that insurance providers should have access to. Now, in the world of modern technology, there's always the opportunity for information to be hacked or not be secure. And so when we talk to folks about pursuing genetic testing when they don't have any symptoms, we do talk about insurance issues. Should you get life insurance, long or short-term disability, long or short-term care in place prior to performing any types of genetic testing? So that's a great question to ask when there's this public availability of genetic testing, but not a lot of conversations pre-test that go into it. And we have had folks who have found themselves in complicated situations because of this lack of knowledge beforehand.
Thank you. And I know we are at time. Do you have a couple minutes to spare?
I can stay, absolutely. I talked longer than I was anticipating, and I kind of rushed at the end there. So if it wasn't as in depth as folks needed or wanted, I'm happy to talk some more.
Thank you, appreciate it. And again, I feel like you covered this already, but wanted to see if you have any additional thoughts on this.
Sure.
How finding out if I have a positive ApoE APOE4 marker or two of them or other genes contributing to dementia be helpful or harmful to them?
So again, as I discussed, this is not something that we recommend. I think that it is something that's certainly out there in the general population. It's not the recommendations now by both the American College of Medical Genetics and the National Society of Genetic Counseling is not to do ApoE testing in folks who are not symptomatic. And it's a rare occurrence in folks who do have symptoms. The reason being is that it's only assessing risk, and it's not something that we would make medical or life decisions based upon, yet some people do that. I mean, I've had someone say to me, oh, I want to know my E4 status so I can decide if I need to, have a retirement fund. If I'm E4 and I'm going to get Alzheimer's anyhow, why do I need to save for retirement? Well, if you have E4, that doesn't mean that you're going to develop Alzheimer's disease. So, or if folks don't have an E4 allele and they say, okay, I'm never going to develop Alzheimer's disease, and they still have quite a significant risk to develop Alzheimer's disease, so we wouldn't, the recommendation against ApoE testing is because it's only assessing risk, and it's not sufficient information for folks to make life decisions just based on that one factor.
Thank you.
So hopefully that helps with that question.
Yes. And I do see a question regarding whether this will be made available, the recording. Yes, the recording is going to be made available on the Blum Center website at massgeneral.org/Blum-Center. And I'll include that link in the chat in a moment. We have another question about, let me see. Mother and maternal grandmother had Alzheimer's disease. What's the likelihood that they will develop the disease? Should they get tested?
So again, when we're talking about Alzheimer's disease, there's other factors to take into consideration. What was the age of onset? Did they, folks who had, did they really have Alzheimer's or did they have some other type of dementia? Frequently folks come in and say, oh, their parent had Alzheimer's. But again, I think sometimes the word dementia and Alzheimer's gets used interchangeably, and perhaps their family member had vascular dementia or some other type of dementia that wasn't Alzheimer's necessarily. Certainly, we ask, is there any medical records that are available for review? Did anybody have an autopsy to try to help confirm that correct diagnosis that both a grandparent and a parent had Alzheimer's disease? As I mentioned, that genetic testing is imperfect for those, even for the rare hereditary forms of Alzheimer's disease. We don't know all the genes that cause them. So testing is always best in the person with symptoms. So if there is a family member that's living with Alzheimer's disease, my recommendation would always be for that person to have testing first. If there isn't a living family member who has Alzheimer's disease, but perhaps they had an autopsy, frequently we can get samples from the autopsy. The oldest sample I retrieved from an autopsy, I think, was 21 years. The autopsy had been performed 21 years previously, and there was tissue left from the autopsy that I performed genetic testing on for a family. So certainly testing folks with symptoms, whether they're living or historical samples, would be the best way to start. For someone who has this family history, again, it's unlikely, not impossible, that it's hereditary Alzheimer's. Again, if their grandmother and mother both had Alzheimer's in their 40s, and there's other family members, then certainly we'd be more concerned about the hereditary form. So I sometimes gather a little more information. I'm always happy to meet with people. If someone has the later onset type of Alzheimer's in their family, grandma and mom develop Alzheimer's in their 80s, it's probably unlikely, not impossible, to be the rare hereditary form. I would talk about the limitations of genetic testing for them. And perhaps maybe there's better ways to get information, maybe at the McCann Center for Brain Health. So it's something that we'd need to gather some more additional information before I would, be able to assess how concerned I was one way or the other about that family history.
Thank you. And I know we have a couple of questions regarding ways to reduce your risk. Feel free to email the Blum Center at pflc@partners.org, because I know Diane had shared a slide with a bullet list of those recommendations, and we can share that with you.
Yep. And again, there's, it's, certainly lifestyle. Just think your brain needs exercise like every other aspect of your body. So sitting in front of the TV, is not good for your brain. Get out, get some exercise, get some fresh air, interact with humans. That's something that's proven to make us live longer and be happier. Humans are pack animals. Being in isolation is not good for us. So interacting with humans doesn't mean being at a party. Say hi to the person walking down the street. Say hi to the person that's delivering your mail or that you run into in the grocery store. So those are things that can happen. Think about that vascular dementia. We want to lower our risk for vascular issues. So reduce your risk for high blood pressure, high cholesterol, watch your diet. So healthy lifestyle, healthy brain.
Thank you. And we have one final question. We have a participant whose husband, father-in-law, and brother-in-law have a history of FTD. What are the genetic testing options for her sons?
So the husband, the father-in-law, and the brother-in-law. So certainly that's a concerning family history. If any of those folks are still alive, those would be the folks that I would recommend starting the genetic process with. Again, because testing for FTD is not all inclusive. And the reason being for that is, say one of these folks unfortunately has an alteration in one of the genes that causes FTD, say the MAPT gene. Okay, so we have someone who has FTD, there's an alteration of the MAPT gene, and that's what's causing their FTD, but we don't have that information. And this son, the offspring of these family, the man, uncle, grandfather, comes in, we're discuss this family history. We know it's concerning for a genetic form, and we do genetic testing for them. And one of the genes that will be on that panel will be MAPT. It's a common cause of hereditary FTD. So in theory, if his testing comes back negative, meaning we don't have any finding, we just ruled out his hereditary form or risk for FTD. But I don't know that because I don't know that MAPT was what was causing FTD in his family members. So there could be great reassuring information there, but I can't interpret it completely because I don't know what was occurring in the other family members. So certainly any other family members, if they're alive, are the best place to start. This son, and we don't test minors for adult onset conditions without intervention. So this son would need to be over the age of 18 before genetic testing was an option. They could be seen for a genetic consult. And we could talk about the family history and pros and cons and limitations of testing. Wonderful. There's also research studies out there too that family members can participate in. Our FTD unit at Mass General has a website. There's research studies, and there's a familial FTD study that folks are welcome to participate. There's eligibility criteria. And that, as part of that, folks are offered genetic counseling and testing too if they want to learn their genetic status. So research is another option for affected folks as well as family members.
Thank you so much, Diane, for spending the last additional 10 minutes in answering these questions. I think that's all
Sure.
that we have time for today, and we went through all the questions. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
No, I'm just happy to be available. I know this is something that's concerning to folks. We all have family members, or likely all have family members, if they live long enough, will have some type of dementia. And we always think, my parents have diabetes, my parents have heart disease, my parents have hypertension, my parents have dementia. What's my risk? We are our parents. So certainly if we have a parent that has some type of medical concern, we ourselves would have this risk. But again, for dementia, there's lots of different causes. Vascular is a common cause, Alzheimer's is a common cause, but there's also these mixed dementias or reversible dementias. And I think the important thing to remember is rarely is Alzheimer's, the most common type of dementia, a genetic hereditary condition with significant increased risk for other family members. And there are other types of dementias out there to think about besides just the Alzheimer's.
Thank you, Diane. And in the chat, I had entered the Blum Center website to access the recording. It should be made available within the next few weeks. All right, everyone, I think that's it. Thank you so much for joining us today.
I hope that was helpful for everybody. Nice to be here. Have a nice day.
You too. Take care, everyone.
Thank you. Bye-bye.